Are increasing inductions due to having improved outcomes and to stop families from being catastrophically harmed? I honestly wish this was the case that we were seeing right now, but it's not, and there are so many reasons behind this. So there are a few caveats that I want to add to this, okay? Our profile of women in terms of health and medical and obstetric history is changing as time progresses. The inequalities in society and deprivation has increased. This in turn does increase the amount of stillbirths, the amount of neonatal deaths, the amount of premature labours that do happen. 20 and 30 years ago, women who had hypertension, women who had kidney disease, heart problems, would have been told that in having a baby, they would have put their own lives at risk. And so many women who were 20, 30 years ago would have been told in these cases not to have had babies. Now, because of medical advancements, which is amazing, these women are having babies, and that in itself does increase the induction of labour rates. And in these cases, absolutely, increasing induction of labours do definitely improve the outcomes. And we know that research has advanced, which means that more women are having things like fetal growth restriction, oligohydramnios, so that's reduced lical volume, detected during their pregnancy. That in itself, because we know that there are huge links with stillbirth, for example, means that these women are being offered an induction that maybe 10, 15 years ago they weren't. 10 to 15 years ago, you would have just had a 20-week scan, and only if there were problems detected during pregnancy from a symphysis fundal height measurement, or from the fact that someone had developed high blood pressure, or, for example, there were another concern that required a scan, they would have had a 36-week scan. And so many more women are having 36-week scans, either because of risk factors or because of other things that happen during pregnancy. We also have far more emphasis on babies' movements during pregnancy than what we did 15, 20 years ago. And so for those reasons, in terms of the maternal medical history, in terms of the additional scans, in terms of the advancements in fetal care during pregnancy, absolutely, the inductions actually do reduce the catastrophic outcomes. But what I want to do now is look at the flip side of this. So these are the statistics. It's highlighting that perinatal mortality overall is increasing. In 2012, when I qualified, the induction of labour rate was set at about 20%. Now, in terms of actual outcomes, in 2012, there were 4.9 per 1,000 women who had a stillbirth. In 2012, this was at 7 deaths per 1,000 births within the first week after birth and also stillbirths. At this stage, the advancements in premature birth outcomes was much lower. The survival rates of extremely premature babies at this age was much lower than what it is today as well, just to make that clear. Now, what is really positive is that stillbirth figure has absolutely come down over the last 12 years. You can see from this graph that perinatal mortality completely reduced up until about 2018, 2019. The final dot on this is 2022. There was a spike in 2021 because of COVID and the COVID mortality that happened, particularly with the increase in women who actually then developed COVID in their pregnancy who were unvaccinated. Now, between the time frame of about 2016 and 2019, where all of this reduction happened, there was a small increase in inductions to about 25%. There was also a small increase in elective and planned caesareans. In this time frame, there was also initiatives such as Saving Babies' Lives and Each Baby Counts, where you can really see that small reduction. Continuity of care came into many areas as well at that stage. I know that there were massive issues there nationally, but because of all of that, the perinatal mortality rate, both stillbirths but also postnatally in terms of the neonatal death rates, decreased. There were also higher amounts of care that was being provided to premature babies at this stage that meant babies who were born before 36 weeks gestation had much higher survival and much better outcome rates than they ever did. A baby who was born at 22 weeks back in 2012 certainly wouldn't have had the same outcomes as what they do now. And there absolutely will be an increase in stillbirths and neonatal deaths with the increasing deprivation and inequalities that exist. And you can see this kind of coming in, particularly where we've had a cost of living crisis that has increased and divided us ever more than before. But what I want to really point out is we've jumped from a 25% to almost a 50% induction of labour rate. And this in itself has huge issues across the country. And we can see this from countries like America, for example, that have really high intervention rates. If you go to somewhere like Finland or Norway, for example, they have much lower intervention rates and the best maternal mortality and perinatal mortality rates across the world, really evidencing that actually increasing intervention doesn't always equal better outcomes overall. So why aren't there always better outcomes when we increase the intervention rates? Well, firstly, there are some risks to having an induction of labour, and that includes increasing caesarean birth rate. Now that, for that woman, if they go on to have another baby in the future, increases the chance of stillbirth. It also increases the chance of miscarriage. It increases the chance of something called placenta previa, which increases the chance of premature birth. Over 75% of all stillbirths happen before 37 weeks of pregnancy. And there's also an increased chance of uterine rupture as well in future pregnancies for women. You've also got to think that over the course of the conservative labour rule over 14 years, lots of midwife-led care units were closed down. Lots of maternity beds were actually removed across the country. And staffing levels have not kept up with the increasing intervention rates either. Induction of labours create a much higher workload and higher pressure for maternity units. 10 to 15 years ago, you would have had one midwife to maybe 3 or 4 inductions coming in. Now that we've gone from a 20% to almost a 50% in some units induction of labour rate, that one midwife is now providing care for about 7 or 8 ongoing induction of labours. And lots of those reasons are for things like raised BMI, for example, a maternal age over 35, things like group B strep. You can name lots of different things that there's not necessarily the evidence to support the reason for the induction, but because there's a just in case there is a poor outcome, we'll offer it to you. That means lots more women are having an induction of labour. And women who have that seed planted in their head of, oh, what if I'm that one in however many? Okay, there might not be the evidence for this, but they've mentioned this word. I'm going to choose an induction of labour now. There's a much higher fear factor there already. And that increased demand without the increased bed capacity or staffing to be able to provide safe care puts women at greater risk. And that's for women who have had caesarean births and post-recovery. That is for women who are having inductions. That's for women going into spontaneous labour. Because inductions do typically take 2 to 3 days on average. They are not quick and easy. Caesarean births means a much longer hospital stay, which means decreased bed capacity. It also means that you need higher staffing resource that isn't necessarily there and providing the infrastructure for. It means that women then don't feel listened to during their labour and birth. It increases the chance of birth trauma. And we know now from the statistics that have come out, postpartum hemorrhage is now sat at 1/4 of all women, 1 in 4, and that's because of surgical intervention, that's because of induction of labours. In contrast, that was about 1 in 10 women 10 to 15 years ago. What it also means is there are more delays in labour and during an induction of labour process or during a caesarean birth. And that in itself can have huge implications for the women who genuinely need an induction of labour, women who have preeclampsia, women who have obstetric cholestasis. Those delays of additional days, fetal growth restrictions, for example, can have huge impacts on the baby's outcomes. But also, if they do go on to have a caesarean birth, or if they have a caesarean birth that's fully dilated, they are more likely to have a premature birth in a future pregnancy, for example. That increases future stillbirth and neonatal death and premature labour rates, which has an impact long term. The other thing that it does is it means that more women distrust us as well overall. And because of the fear and anxiety around induction and caesarean birth, there are more women now pushing against the system. And what I mean by that is if you keep constantly hearing alarms going off, you eventually just ignore them. When healthcare professionals start recommending induction for literally anything, even if there isn't any evidence, when it comes to genuine medical need, genuine medical evidence that exists, lots of women start pushing back against that. Because what happens is, say for example, their best friend had an induction of labour, was told she needed to be induced because of their BMI of 35 without the evidence. Well, when they themselves are recommended to have an induction of labour for something like fetal growth restriction, where there's much higher chances of stillbirth, they start pushing back and going, yeah, but my friend had birth trauma from that induction or from that caesarean, and I don't want that. And they stop believing the genuine reasons that really do save lives, reduce stillbirths, reduce neonatal deaths. We then have more women declining medical advice and going against that medical advice, which is entirely their choice, but we've almost created this storm.